Hello, all my friends out there in the Dinks world. I have JB on the screen with me.
He let me come up early.
Yeah. You know what? Chad's not here. That means we can have fun tonight.
We can do whatever we want.
Because I can convince you to be really positive tonight, and we won't have that Chad bringing us down.
Always.
Yeah. Hey, guys, this is Jeff Horowitz. Yeah. This is Jeff Horowitz with Dennis in the Know, and welcome to Humpday Happy Hour. I'm with Dr. Jennifer Bell, and unfortunately, Dr. Chad Duplantis couldn't be with us tonight, but we're going to have a great show for you anyway. So you know the routine, what we do here. We are all dentists, we are all educators, and we are all practice owners. And we kind of think it's our job to help bring you in the know. So we're going to have something light or not so light to drink. We're going to have some great conversation. We're going to have some fun. And tonight we have an amazing periodontist that I actually got to study under a little bit, learning about one of the new additions from the DECA laser lineup, which is their Nd:YAG laser. And we'll be talking about that tonight. We'll be talking about laser-assisted periodontics. So anyway, we've got a great guest tonight, JB. And you haven't formally met Dr. Avi other than just before the show, but Dr. Avi Schetritt is with us, and amazing periodontist. And I'm excited because we really haven't, I don't even know that we've ever had a periodontist, have we?
We had Dubrow.
Oh, yeah, we had Jennifer Hirsch. Yeah. That's right. Jennifer Hirsch Dubrow. But it's really interesting. We've not ever had the discussion about laser-assisted periodontal therapy. So, and I think this is a really hot topic right now. What I got to witness at his office was absolutely amazing. And so I think we're going to be seeing and hearing a lot more about this. So I'm anxious to talk with him. But before we do that, you have a little bit of,
I always have news.
Okay.
And unfortunately, I have to say, North Carolina did make the news this year or this week. So got that going for us. So first story of the night, we had a North Carolina orthodontist who I went to school with. Great, solid human, really is. But he did happen to make national news this week with his infamous program, Grins for Glocks. It was supposed to be a private offer where he was working with a local gun club. I believe he's affiliated with it somehow, where they were doing, you could get Invisalign done, and in exchange for deciding to close the Invisalign for the day, you would receive a gun. Now, he defended this by saying they were all background checked beforehand. Like, they did do all the due diligence, and probably the majority of them were members of the gun club or affiliated in some way. So it wasn't just this mass distribution. Certainly was intended to be a private promotion, but it did escalate very quickly and was in the local news the very next day and hit national news by Friday. So
yeah, I think, made our local news.
Yeah. So anyway, Godspeed. I wish Gladwell the best of luck. Hopefully this, just dusts over, or heck, it probably just grew his business tenfold. Exactly. Because no press is bad press. So we'll see what comes of that. But certainly we did make the news this week. Another interesting story. I hope Chad gets to see this because I thought he would find this most interesting because of his affiliation with a particular study club, which we'll talk about. But a former dental manager was convicted of embezzlement to the tune of $130,000 from a Washington office that she was using to live a fairly lavish lifestyle, which we would do if we happen to have an extra $100,000 sitting around. Unfortunately, though, I have to say this wasn't her first encounter with doing something very similar. So you'll find this super interesting. It was back in the 2010s where she first kind of came on the scene with this idea, I guess, maybe, of how she could swindle through some additional money. by being a coordinator at the Seattle Study Club. So she worked for the Seattle Study Club for a few years, and during that time managed to rack up $35,000 in fraudulent credit card charges. She felt great remorse from that decision, and so she was let go. She admitted guilt, but Seattle Study Club, being very kind, did not press charges. Well, fast forward a little bit later, she ends up in another dental office, Gentle Dental, which I believe is a chain, or at least we have some around here, where she was able to amass about $40,000 in cash from patients who were trying to pay a bill. That did take her to court, but she got off admitting guilt, but only had to pay a fine and served a 1 month in jail. But then fast forward to today in 2017, she started the similar practice again of embezzling from the practice, and this time got up to $130,000 before she got caught. What's the moral of this story? Well, interestingly enough, when I was preparing for the news tonight, there were so many stories of embezzlement hitting different news channels that I follow in the dental world. And I thought this is becoming much worse. And I think with the economy and being what it is, obviously she was a repeat offender, but I think you're starting to see these things pop up more and more. Number one, we've had a great guest. If you didn't watch the show when David Harris was on and he talked about embezzlement, he was fantastic at giving pointers on how you can stay on top of your books to make sure. Independent audits of folks not affiliated with your practice is also really important. I'm not sure a background check on this particular person wouldn't have pinged that one conviction and jail sentence. So that might have been at least a way to pre-screen. So, we can't let our guard down. We have to continue to do our due diligence. And these individuals are often very likable and very nice people. They just happen to have a bit of a playbook that they're coming from. So keep that in mind as well. The last thing I wanted to mention was the ADA put out some kind of an update around their HPIs. Those are the statistics they've been tracking for the last few years, and kind of gauging workforce, gauging dentist activities, and what the kind of boots on the ground of what's happening on the ground level for dentists, and how the practice environment is evolving over time. And no surprise, we're seeing some interesting things come out that I don't think will surprise anybody who is a fan and watches the show frequently. Dentists are expanding what they're providing in their offices, and not by what you think. I'm not talking about maybe expanding into root canals or implant therapy, though they may be doing that to address busyness issues. But they are also starting to pick up more and more duties that might normally be assigned to admin, assistants, and hygienists. I know in my own practice, we are picking up more prophies on the doctor's side for one of my practices because the patient population sort of lends itself that way because of the challenges of finding a full-time hygienist to come in and be a part of our team. So, that statistic definitely hit home with us to say, yeah, absolutely. In our practice, we are seeing a shift of roles and responsibilities within and accommodating for those challenges. And again, they're reiterating the continued statistics of the number of private practice owners continues to go down. We're seeing, again, that movement towards consolidation. And those young dentists, this was an interesting statistic, Jeff, I think you'll find. A lot of times we talk about the young dentist typically goes towards the DSO and they want to build up their speed and kind of work in that environment. This statistic highlighted whatever the dentist decides to do upon graduation, whether it's a DSO, private practice, mentorship, whatever, they typically will stick with that now for about 5 years. So it means that if they go into the DSO, it's a more mindful decision that is likely the type of business and practice they want to pursue. And for those that go on to open their own or join a private practice, it's kind of in their DNA that that's what they want. Instead of, I think in my generation coming through, you definitely saw more of I'm going to go to the DSO or the group practice, get my skills up, maybe find a great mentor who will help me through some challenges. But ultimately, I would like to own my own practice. So it's kind of an interesting shift to say, it looks like when folks are graduating, they're sitting still for a little bit longer period of time. And they do not cite debt as a primary motivator for their career choice.
That is interesting.
Correct. That kind of struck me. I was like, we've been spouting off at the mouth. pontificating about how debt was going to dictate decision making. But at least currently, and most of these students are in significant debt at this point, but that doesn't seem to be dictating their first early career decisions.
But haven't we seen from kind of this from this generation, kind of this concept of idealism anyway?
Yes.
So it's really not that unusual. I mean, it's surprising, of course, because logically that should be the biggest thing that they're thinking about.
Yeah.
But really, they just want to maybe have the right lifestyle for them, that maybe that is, the primary motivator for them, as opposed to, where they're going to be. And maybe they don't want the stresses of owning a practice. Maybe they don't want, maybe they think they'll just work up the corporate ladder and just punch a clock and make a great salary and go home and get 4 weeks of paid vacation until it doesn't work out that way.
Yeah, absolutely. I don't know what the right answer is, but it's definitely something to keep watching.
Yeah. No, now I'm really interested. So, great stories, rich and compelling.
Why, thank you very much.
Anyway, let's bring our guest on, JB, because I'm really excited that Dr. Avi was able to make it to the show. So, Avi, I'm going to go ahead and bring you up, and I'm going to do a little introduction. So here he is, ladies and gentlemen, Dr. Avi Schetritt, who I had the pleasure of meeting at Deerfield Beach in Florida. Dr. Schetritt is a board-certified periodontist. He grew up in Montreal, Canada, where he finished his studies at McGill University and then went on to receive his Doctor of Dental Medicine at the University of Montreal. Bienvenue, Avi!
Merci.
After 2 years in private practice, Dr. Schetritt attended the University of British Columbia, where he completed a periodontal residency program. And he is now a diplomate of the American Board of Periodontology and a diplomate of the International Congress of Oral Implantologists. Dr. Avi, as he likes to be called, is a devoted educator, lectures nationally and internationally on soft tissue procedures, laser periodontal therapy, bone regeneration, and implants. And he's authored several articles and textbook chapters on these same topics. So, Dr. Avi, thank you for joining us.
And thank you very much for inviting me, Jeff. It's a pleasure to meet you as well, JB. And I enjoyed the stories, or the news stories you shared. And it's interesting, the last comment you were talking about the lack of graduates who want to go into private practice. And I can tell you, I have 2 children that have finished university, and for them, not in dentistry, but it's the lifestyle is a huge factor in their decision making for looking for a career. So I think that's a big part of it.
Yeah, I agree.
I honestly think some of the new grads just don't want to work as hard as we do.
Same.
It's still amazing because we're trying to apply our logic to a different mindset, and it should be obvious to us that there's a different mindset, but we still want to impose our own logic on it. So,
well, I'll tell you, it was a very telling moment for me. My daughter, who's 21 and is going to graduate with a graphic design major, when we started talking about university, I said, why don't you consider dentistry? You've got, A, a mentor, and B, an opportunity to join a practice. And she looked at me and she said, I don't want to work as hard as you do.
Yeah. I think my oldest son is of that mindset.
There you have it.
JB, what were you going to say?
Well, to their credit, they have better work-life balance. So, it's like finding the balance between the different.
Isn't that what this is for?
Yes.
Cheers.
Isn't this work?
Cheers, absolutely.
Cheers, by the way.
Absolutely. But yes, I've observed it in my own associates, when we bring in younger grads to come into the office, very few of them are looking for full time, and are going to work the way that, at their age, I was doing 3 different jobs. I just wanted to get good at what I was doing, and would not turn down any opportunity to treat a patient because I knew I had so much still to learn. So just a different, either my own lack of confidence or a different mindset, but there was no end to my ability to want to push forward and be better.
So I would say that's something that really is deeply ingrained in you, or it isn't, where you just want to excel at whatever it is that you're doing. And I don't know if that is taught to you by your parents or if it's just something that's born into you, but you either have that or you don't. And it doesn't mean that you don't want to be clinically adept. It just means that you don't want your work life balance to suffer as a result of getting to that level, which I've always been okay with, good or bad. Most people would say bad.
Well, Dr. Avi, can you tell me a little bit, since, we're just meeting for the first time, I would love to hear a little bit more about your journey and your story of, deciding to become a dentist. What did that look like? Did you come from a family of dentists and that's what pushed you in that direction? And then, sort of how you ended up in perio and just that whole kind of diagram.
So my pleasure to share that. So no, not a family of dentists. I come from a blue collar family. I grew up in Montreal, Canada. And at a very young age, I decided I wanted to be a dentist. I think it's because I had so much dental work as a child. And the dentist we had, Dr. Stanley Bloom, I still remember him. Very gentle person. I admired him. And I decided, I was fortunate very early on in high school. I knew I was going to be a dentist, and I did a bachelor's degree with the hope of attending dental school, and I just followed that path. So I did a bachelor's first at McGill, as Jeff mentioned, bachelor in anatomy, focusing on cellular anatomy. And I know I look very cool and suave, but I actually was a geek and a nerd in school. But I went on to dental school. I loved it. And I had 2 mentors. I had actually the director of the perio program, Jean Turgeon, and the head of the graduate perio, well, sorry, not the graduate perio, but the clinical perio, Alan Shapiro, who mentored me. And I just loved perio. I really, really loved it. I just liked the medical aspect of it. I liked the microbiology. And so I practiced for 2 years, and I'm not going to say I was bored, but I found it somewhat overwhelming, to be honest with you, to do everything. And I decided, you know what, I'm going to go be a periodontist. And at the time, in Canada, there were only 2 schools. There was University of Toronto and University of British Columbia that offered the perio program. So Toronto had 8 spots per year. UBC had 4. So there were basically 12 spots available in Canada, and I was fortunate enough to get one. So I did the perio residency, and I never looked back. I mean, I just love perio. I love the interaction with patients. I love the technology. One of the things that was interesting to me, and still to this day, as far as dental literature, perio has the longest history of actually having scientific literature. So I learned very early on to base my decision on scientific research. And I think that's huge because, a lot of the stuff that's sold today is anecdotal. And whenever a rep comes into the office and says, you got to try this product, it's amazing. And I go, why? What's the research? So, show me something, some literature. So that's basically my background.
So, Avi, on that note, let me just, for everyone out there, where I met Avi was at a course. You all know I'm a big advocate for lasers. I've used the DECA CO2 laser for a long time, got to know the company very well, got to know the quality of the products incredibly well. And they actually decided to bring on an Nd:YAG laser, which I was very excited about, to begin this journey into laser-assisted perio. And DECA has been around in the medical arena with lasers and other technologies as well forever. But my first real deep dive into this, because I was excited about what it could do, as you said, Avi, the literature has to be there. There has to be the information to support this. And of course, we know Nd:YAG has been used for a while in this arena for regenerative therapies, periodontal therapies. But when this came out, I said to Justin Mangelsdorf, who is the president of DECA US, we really we need to learn. I mean, we need to learn the biology here. We can't just go out. You can't just put this in the hands of people and say, here's a clinical technique. This is what I want you to do. We need to understand the science, because, you know, I've always said, and JB and Chad are the same way, it's okay if you want to take on procedures that specialists do, but you better be able to provide those services at the level and with the same understanding that the specialist can provide it. Otherwise, it absolutely needs to be referred. So I met Avi at his office in Deerfield Beach, Florida, and was just so impressed. He did a presentation for us. We saw some patients at his office. And so maybe what we should do here is tell us when your passion or your interest in laser-assisted perio began, and tell us a little bit about that journey, where that's gone from the early implementation of Nd:YAG laser in periodontics to where we are now, and some of what you're doing in your office.
Absolutely, Jeff. So, you know, I'm going to date myself a little bit, but I was trained with resective surgery. So I was trained that when there's a periodontal patient, you basically open up the gums, scrape the teeth, and stitch everything back up. And for those of you who have had the procedure or performing the procedure, you know that it's quite traumatic to the patient. You end up with exposed root surfaces. There's a lot of post-operative sensitivity. The teeth are considerably longer. You know, I like to tell the story of my graduate program director. His name was Hanu Laryeva, and he had a sign behind his desk that said, "It's better to have longer teeth than no longer teeth." And what that refers to is essentially resective periodontal surgery. And it works. I mean, you can take a 7-8 millimeter pocket and turn it into a 2 or 3 millimeter pocket if you cut away the gum, essentially. But there's obviously cosmetic issues post-operatively. There's thermal sensitivity issues. So I was always looking for a more, or I should say, a less invasive way to treat periodontal disease. You know, just like in the past, we used to do free gingival grafts, I'm now doing considerably more connective tissue grafts for root coverage. And, you know, the problem with periodontal disease is that the bacteria that cause periodontal disease are normal oral flora. So you're never going to eliminate them. Obviously, it has to do with the quantity of those bacteria, the transformation. You know, we thought it was bacteria initially, but it's actually a biofilm, which is a colony of bacteria that adheres to the tooth, and it's very difficult to eliminate. So I guess the Nd:YAG came on the scene about 15 years ago. And, you know, I would see some anecdotal x-rays of patients who have had it, and the results were astounding. To perform essentially a non-surgical procedure. And, you know, when you think of surgery in the conventional way, you're thinking of cutting and opening up the gums and, you know, using a 15 blade. So I said, well, I've got to look into this, because either it's all smoke and mirrors or there's something to it. And I was, at that point, about 15 years ago, discouraged by the lack of science behind it. Nobody was sure how it worked. There was some biostimulation effect of the Nd:YAG laser, but they weren't sure why. They weren't sure how. You know, certainly it killed bacteria. We know now that it disrupts the biofilm. It also targets the pigmented bacteria that are most often associated with periodontal pathogens. So after, speaking to some colleagues, looking into it a little bit more, I took a leap of faith and I decided to purchase an Nd:YAG laser. And to be honest with you, I was shocked with my own success in the sense that the results were astounding. They were really far superior than what I had anticipated. And I can tell you from my practice's perspective, it's been a huge boost because patients who have had periodontal surgery don't want to do it again, conventional resective surgery. And patients who are apprehensive about periodontal surgery because they all go on YouTube and see horrible things, like the idea of a laser treatment. Lasers, as you know, are in vogue for all sorts of medical procedures, both curative and cosmetic. So I think the timing was perfect in the sense that lasers are becoming more sophisticated. Their applications are greater. And for my personal practice, I see the advantage of using the Nd:YAG laser. And when DECA came out with their Nd:YAG laser, like you, Jeff, I had a lot of experience with their CO2 laser, which was, to me, the best soft tissue and is today the best soft tissue laser out there. But the applications to periodontal therapy were limited because they're not using a fiber optic. So the ability to get into a pocket that's 8 or 9 millimeters deep is very limited. The Nd:YAG uses a fiber optic delivery system. So that fiber optic, or that fiber rather, is 300 microns in diameter, which is small enough to insert to the depth of a pocket and deliver the energy, and deliver it in a very precise way to affect only the soft tissue surrounding that tooth and the essentially the root surface. So I've been using it in the practice for over 10 years now, not the DECA per se, because they just introduced it about a year or two ago. And the patient acceptance is incredible. Results are phenomenal, but also post-operative sensitivity is virtually non-existent. People that I see, so typically I'll see them at a week follow-up, and 90% of the people tell me, I took a Tylenol the first day, and then I'm not even sure you did anything because I had no pain, no swelling, no bruising. Whereas in the past, when I did 4 quads of osseous surgery, I didn't want to see them the week after because they'd be really upset with me. I'd wait for 2 weeks. But I think certainly for every practitioner, not just periodontists, I think it's really an adjunct to conventional periodontal therapy. What the other thing that's, I think, huge in my practice is the treatment of periimplantitis. So I'm going to date myself. I did my perio residency in the early 90s. So I know I don't look that old, but I am. And, so in the early 90s, Brannemark was on the forefront of implant therapy. And my colleagues were saying, well, that's the end of perio. That's the end of endo. Everything's going to be an implant. Turns out they were completely wrong. And, at least in my practice, I'll see 2-3 periimplantitis cases a week where the implant was placed a few years ago. Everything was fine, but now there's bone loss around that implant. And conventional therapy is not ideal. I mean, essentially, you're going to have to open up that implant, try to clean it out, and graft the area if you can. But the decontamination of a contaminated implant surface is almost impossible because of the microporosity, the micro structure of that implant surface, which is great to attract bone, but also attracts bacteria. So I think on both fronts, on periodontal disease and peri-implant disease, the Nd:YAG is really quite revolutionary.
For our general dentist folks out there, can you give them some post-operative guidelines about what they should be doing to manage if it's a co-share patient where, they're going to return back to their GP at that point? What are some of the guidelines that they should be adhering to in their practice for perio maintenance of those patients? And then also, what's the expected life expectancy of those treatments? Nothing's forever. So, you go in and do laser treatment today. What's a reasonable expectation in which that may or may not need to be retreated again?
You know what? That's a fantastic question, JB. And what I tell my restorative colleagues, my referral base, but also my patients, is the determining factor is patient home care. And I tell my patients that because I can go in there and do the absolute best surgical, non-surgical therapy that I am able to do. But if they don't follow up with adequate home care, it's bound to fail, and it'll fail quickly. It'll fail within a year or two. Whereas if someone maintains adequate oral hygiene and maintains follow-ups, and I'm a strict believer in the 3-month follow-up. However, having said that, I have some patients that are on an 8-week follow-up because their home care is just not adequate. But if they're compliant with home care and the maintenance visits, and I tell patients this too, I may have to retreat an area or two, 5-6 years down the road, but it's very unlikely I'll have to retreat the entire dentition again. One of the things I want to stress too that I don't think we talk about enough in dentistry, at least when I was in school, in my initial dental degree, is occlusion. At all our recall visits, I take that little blue paper and I check occlusion, because occlusion, as you know, is not static; it's dynamic. It changes almost daily, and if there's excessive non-working contacts, if there's excessive off-axis loading, both of teeth and implants, the periodontal structures are going to suffer. So it's a tough follow-up in the sense that it's not just you're going to come in and get your teeth cleaned. We've got to check the occlusion. We probe regularly at our recall visits. We monitor patients carefully because I think it's very easy to correct something when you see it right off the bat. Whereas if you don't see it for a year after it's happened, there's a lot more destruction going on.
For sure. Absolutely.
I don't know if that answers your question.
Yeah, no, absolutely.
Sometimes I just start talking and I lose track.
I thought it was perfect.
No, this is amazing. So I think one of the things that I was really taken back by is, as you mentioned earlier, we saw the pendulum swing in this direction of, oh my goodness, this tooth has a 5mm pocket, take it out, put an implant in. This tooth has decay that's approaching the crestal bone, take it out, put an implant in. Why are you messing with something that's unpredictable? And what we've learned over the years is, guess what? We have a lot of the same problems with implants, maybe not caries, but we have a lot of the same periodontal concerns with implants, even though the histology is a little bit different. It's essentially the same problems that we're finding, and it needs to be managed probably even more closely. And so what took me back at your office were the first case that we did, I say we, that you did, I watched. But when we were there, the first case was one that all of us in the room looked around and said, every single one of us would have told this patient to have that tooth out. And in fact, that patient came to you because they were told that they needed to have the tooth out and have an implant put in. And yet you were able to offer not a guarantee of success, but you were able to offer some amount or some realistic longevity expectation to the patient. And they were great with that. And so, dentists always think in terms of, well, this is what's going to last longest. So this is all you're allowed to do. But yet several of your patients that were there were really, look, I don't know what else to do. They're telling me to get my teeth out, and you're my last hope, Dr. Avi. So maybe talk a little bit more about that, about how quick we are to doom teeth, and how many people are so into this thing of absolutes that you have to do it my way or no way at all.
So I'm going to tell you an interesting story, and a patient I actually saw this week. So this patient came to me 7 years ago in tears, saying that her dentist said all her teeth had to come out. Not 2 or 3, all of them. 32 teeth because there was a full complement of teeth. And person in their early 50s, and I looked at the radiographs and I did my clinical exam, and certainly one could say, yes, we're going to take out all your teeth and put you on an all on X type prosthesis, and we're done. But I think nobody thinks about the psychological impact of that. Well, I shouldn't say nobody, but to tell someone who is dentate you're going to lose all your teeth, I think psychologically is traumatic. And I said to her, well, because she found me through my website that we do laser therapy, and she said, as you had mentioned, Jeff, it might be my last hope. I said, you're in bad shape. We're not going to be able to save all your teeth for the rest of your life, but if you're willing to trust me, we're going to try some laser therapy. I'm going to see you every 3 months. I may see you every 2 months. And I can tell you, I saw her this week, and out of 32 teeth, we lost 4 of them in a 7-year period. And she is so grateful. Every time I see her, basically she thanks me for saving her teeth. And those are not uncommon stories. I think we're very quick, our dental colleagues. I can tell you, especially the young ones, depending on where they were trained. I was trained to do root hemisections. I was trained to do root amputations. And some of the older colleagues I work with will still do that. And it works. And I try when I go out and speak about implants, when I speak about laser therapy, to try to impress on our colleagues that even a periodontally involved tooth with a poor prognosis, with proper treatment and maintenance, I can keep that thing alive for years. Maybe not 10 years, but certainly 4 or 5. And as long as we don't have progressive attachment loss, I can take out the tooth when we decide it's the right time for the patient. So I think we're really quick to look at long-term prognosis of a tooth and condemn it. But I think we also have to take into account that, an implant may be the best thing to replace a missing tooth, but it's not as good as the initial tooth. Biomechanically, it doesn't have a periodontal ligament. It's susceptible to periodontal disease just as much as a tooth is, and to some extent more so, because the soft tissue attachment to an implant is not as strong as that of a tooth. So the loss of attachment occurs quite rapidly. So I think it's almost incumbent upon us as the older generation of dentists to impart a little wisdom in that, don't be so quick to condemn a tooth. A crown lengthening is a perfectly good solution to decay that's gone subcrestal. I have done root amputations. Typically, it's the mesiobuccal root of a maxillary first molar, and it works. If I have one bad root, why am I going to condemn a tooth that has a huge palatal root and a distobuccal root, where we can maintain it even if it's for 5 or 6 years? It works. So I think that's crucial, and I think the laser helps me do that because it's non-invasive. The results are good, and in an infrabony defect, if I do a thorough debridement of that infrabony defect, I will get regeneration. It's you have to let the body heal itself, and it will if you remove the bacteria that are causing the inflammatory reaction.
For doctors who don't have an NDAG or aren't in a financial place to acquire one right now, I think the AAP did come out sort of more open-ended on at least using laser therapy of any wavelength might have value. Can we talk about that a little bit?
Well, I don't want to poo-poo the AAP, but because that would not be the appropriate thing to do.
Fair.
But so let's move on from that. I will tell you too, I'm disappointed I'm not the first periodontist you've had on your podcast, but we're at episode we're at episode 170, so I guess that would be presumptuous of me.
Yeah.
I think part of the issue with periodontal therapy, there's when we look at periodontal disease, in my mind, there's 3 things. There's bacteria, there's host response, and there's occlusion. And I think mechanical debridement alone, as far as getting in with curettes, especially in a closed, unless you're going to flap it, is very inefficient. Root surfaces are not smooth. Our instruments, certainly in furcations, cannot go into the furcation area. So I think any laser, even a diode laser, with appropriate training and appropriate settings, will go in there and at least disrupt the biofilm, and that's crucial to allowing that pocket to heal. So I think just about any laser therapy as an adjunct to conventional mechanical therapy will be beneficial. Certainly, you're not going to get the biostimulation effect. You're not going to get the targeted effect that the Nd:YAG has on red pigmented bacteria, but you're still going to have an effect that's beneficial.
Yeah.
Will you talk a little bit while we're on this topic, because I mean there really are, what I've learned, several distinct advantages to using an Nd:YAG for this application. And one of them is the ability to actually seal off the sulcus to some degree. One of them is obviously the ability to target specific bacteria. And then, but certainly that biostimulation component, I think, is huge. Would you just talk to maybe what you see as the distinct advantages of using an Nd:YAG, as opposed to, basically every laser company out there is saying you can use this for, and they all have these types of assisted perio procedures. And but I think it's important to really talk about some of the science and say, yes, you will disrupt biofilm, you'll kill bacteria, and there will certainly be disinfection. But what are some of the distinct advantages of using Nd:YAG?
I think the wavelength lends itself more to periodontal disease. First of all, it essentially targets periodontal pathogens. It also, because of the fiber optic configuration, we know in periodontal disease that the bacteria are not just in the pocket; they actually infiltrate into the soft tissue, into the crevicular epithelium, and into some of the dental tubuli. So in order to essentially disinfect that area, you've got to eliminate bacteria in those reservoirs, and that's where the Nd:YAG really shines. If we look at a diode laser, the energy is really focused at the tip, whereas the Nd:YAG is radiating apically and downward from that fiber. So it's going to eliminate, or essentially remove, the crevicular epithelium that has bacterial infiltration in it. And lastly, as you mentioned, the ability to biostimulate, the ability to stimulate the non-differentiated mesenchymal stem cells in the cancellous bone around the tooth, and differentiate those into osteoblasts to form new bone, and cementoblasts to form new cementum, to create true periodontal regeneration. And there is literature out there, human histology, that shows that after the use of an Nd:YAG laser, these were on patients who had the teeth subsequently extracted and block sections taken, you actually see new cementum forming, new periodontal ligament, new bone, which is the definition of periodontal regeneration. So it's really the only laser wavelength to be able to do that. So from that perspective alone, I think that's the gold standard as far as periodontal laser therapy.
Are you able to expand your Nd:YAG usage? Because you talked about the CO2 laser as well. Is the Nd:YAG just your perio workhorse? Is it just doing perio treatment? Are you able to expand that out to other soft tissue applications? And how are you balancing your use between a CO2 and the Nd:YAG?
Well, I could expand on it, JB, but I choose not to.
Okay.
I'm joking, of course. I thought we're going to have some light banter here.
Great question.
You know what?
She doesn't know you that well yet.
I see. All right.
Yeah, but hey, I think we just got there.
Yeah, we're there now.
We're there now. Game on.
I just needed a window.
Okay, there you go. So I can tell you, in my practice, yes, you can do other procedures with the Nd:YAG. You can use it for gingivectomy. You can use it for frenectomies. But I find it not as precise and not as focused for soft tissue procedures as the CO2 laser. the CO2 laser, in my mind, specifically the DECA Ultra Pulse laser, is the number one soft tissue laser. I use it for, I mean, essentially with the settings that you can modify, I can remove one cell layer at a time. So it's extremely precise. It gives me a lot of control. It obviously creates hemostasis as you use it. So there's very little bleeding. There's very little post-operative discomfort. So to me, the CO2 is the laser I want to use for any soft tissue procedures, gingivectomies, frenectomies, removal of a mucocele. Very, very effective at doing that. Can you do it with the Nd:YAG? Yes, but it's really, at least not in my hands, as efficient or as effective. The fiber optic is, I'm not going to say flimsy, but it's really designed to go to the depth of a pocket, to cut something out or use that as your end tip for a gingivectomy. I find is really not as efficient. What's nice about the CO2 is it's a non-contact laser, so I'm actually not touching the tissues with the laser, so the penetration, depending on the setting, is not as deep. I have much less charring of the tissue, much less burning of the tissue. So I think I'd love to say there's one laser that'll do everything, but that's just not been my experience. And I think the CO2 is your laser for soft tissue. Absolutely the best laser out there, the DECA CO2. And for periodontal procedures, I think the Nd:YAG is the way to go.
That's I'm so glad that you said that, because I think so many dentists are talked into, you can do everything with this laser, and on the showroom floors, and I get it. You want to try to consolidate as much as you can, but just based on the science and the wavelengths and the chromophores and what each wavelength is going to be absorbed by, there is no laser that can do all those things. There is no laser that's going to be great on bone that you're going to be able to go into a sulcus and do what you're talking about doing with a 300 micron fiber optic lead. So there are so many, I think the most important thing as far as lasers go are understanding what your laser is good at, what your laser isn't good at, and just saying, if you really want to do a procedure that there's another wavelength that's better, then do that. Go into it that way, and it will be absolutely worth it. And I guess that's what I've appreciated about DECA so much, is that they've actually spent the time with me for me to truly understand the science behind what they're trying to do. And they're not trying to be here, just buy our CO2, this does everything. Just buy our Nd:YAG, this does everything. Here's what these do. If you want to start with the laser that'll do the most procedures for you, great. But there is no one laser that can do it all. And I think that's such a powerful message.
Absolutely.
Yeah. JB, we're at 9:30 already.
I know, it went by so fast.
By the way, did you hear he said penetration?
I didn't want to bring it up.
Yeah. See,
really?
Avi, we can have fun.
And on that note, I'll bid you both good evening.
We're going to close the show.
This is why there's no HR department at Dentists in the Know.
Yeah, thankfully.
And why our editors stay very busy after.
Yes, we keep them busy. Anyway, Avi, thank you so much for being on. I would love to, well, first of all, I was sorry I didn't get to be with you at the last meeting. But look forward to being with you again and learning more from you, because I just picked up so much in your office and appreciate what you're doing for patients and appreciate your open-mindedness and even with that, your open-mindedness in the context of still following what the literature tells us is the right thing to do. So what a pleasure it was having you.
Thank you very much, Jeff, JB, for inviting me this evening. It was a lot of fun, and I look forward to seeing you both again.
Absolutely.
Absolutely. JB, you want to close us out?
Thanks. It's been another week in the trenches, but we really appreciate you hanging out with us, and we hope you'll join us again next week. It will be Thanksgiving, actually. So hopefully you've got some fun holiday plans, and looking forward to catching up with everybody. Hope you have a wonderful rest of the week, and we'll talk soon. Have a great night.
Good night, everyone. And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.